Carol, a 68-year-old female librarian, presents to the ED with moderate shortness of breath, times about 3 days, swollen lower extremities, and fatigue. Carol takes a moment to clear her head and then states that just a few days ago, she spent an hour or so playing in the snow with her twin grandsons. The boys are from Georgia and have never seen a proper Christmas snow, so Carol was very excited to experience the snow with them in post-apocalyptic Illinois. She has a history of COPD, sleep apnea, anxiety, depression, asthma, and hypertension. Her ex-husband was a multi-pack-a-day smoker since the age of 15 and smoked the 12 years of their marriage until his untimely death. Carol jokes that, "I know a dusty old library probably isn't the best place for someone with breathing problems, but I just love it here. It's the first thing, besides my boys, that I've enjoyed since the apocalypse ended." Past medical history. Carol has a history of secondhand smoke exposure. Both of her parents have smoked as long as she can remember, 18 years of exposure with them, and then 12 years during her marriage to Ed. She has a history of lung cancer on her father's side of the family, a history of seasonal allergies, and has had asthma since childhood. Carol is an average height Caucasian female. She presents to the ED alert and oriented times 3, with intermittent confusion to time, barrel chest, shortness of breath, and a bit of wheezing with any activity. Her vital signs are as follows: a heart rate of 94 beats per minute, respirations of 22 breaths per minute, slightly hypertensive with a blood pressure of 142/81, and oxygen saturation of 90% on 2 liters by nasal cannula. She denies any fever, and she is breathing with her accessory muscles, taking breaks to recover between sentences. Upon auscultation, we hear expiratory wheezes and diminished breath sounds bilaterally. On the telemetry monitor, she is normal sinus rhythm, her EKG is negative, and she is negative for elevated cardiac enzymes. Her abdomen upon palpation is non-distended, soft and non-tender, slightly rounded, with normoactive to sluggish bowel sounds. She says she goes to the restroom about every other day, so this is normal for her. Her hands are cool to touch, her fingers are clubbed, her pulses radially are 2+, and her dorsalis pedis pulses are 1+. Her bilateral lower extremities have edema. As mentioned before, she is alert and oriented times 3 with confusion to time. She was confused that the year was 2012 a couple of times. A Glasgow Coma scale of 14. Strengths are 4+. Her senses are intact, and her gait is steady with standby assist for ambulation. Pulse oximetry reveals that she is 90% on 2 liters by nasal cannula. Upon drawing abnormal blood gases, or ABGs, her pH is 7.29, CO2 of 73, bicarb of 28, PO2 of 51, and SpO2 of 89%. She is in respiratory acidosis. A chest X-ray reveals positive for emphysema. A CT of the chest shows damage to the walls of bronchial air sacs, and her CBC shows that she has elevated sodium and a hematocrit of 28%. So, an exacerbation of COPD or a flare-up is when symptoms of COPD become suddenly much worse. This can last days, weeks, or even months, and can be treated with antibiotics, oral steroids, or even hospitalization. The pathophysiology of this process is irritation, followed by inflammation and pathological changes. Risk factors include tobacco smoke from cigars, cigarettes, pipes, and environmental tobacco smoke, dust such as that on a dusty library bookcase, Chemicals, like those emitted from harsh cleaning supplies. Indoor air pollution, such as fumes from natural gas used for cooking in a poorly ventilated home. Outdoor air pollution and chronic inflammatory diseases, such as asthma. On to the patho. So irritation is caused by smoking, environmental irritants, etc. that trigger inflammation in the lungs. This inflammation releases antioxidants and antiproteases. These prevent the breaking down of proteins into peptides and amino acids. This causes oxidative stress, leading to pathological changes in the lungs, including but not limited to increased respiratory rate, inadequate gas exchange, increased heart rate, and increased blood pressure. There are two conditions that heavily contribute to COPD that often overlap one another: chronic bronchitis and emphysema. In both conditions, irritation caused by previously mentioned risk factors called neutrophils, lymphocytes, and macrophages to the lungs. This triggers inflammation, oxidative stress, extracellular matrix proteolysis, and cell death, resulting in progressive damage to lung tissue. As if COPD weren't bad enough on its own, COPDers are more at risk for pulmonary hypertension and right-sided heart failure. When right-sided heart failure occurs independently of left-sided heart failure, it is usually the result of pulmonary hypertension caused by diffuse hypoxic pulmonary disease, such as COPD. Carroll's risk factors are as follows: tobacco smoke exposure, history of asthma, exposure to dust, both occupational and at home, and exposure to natural gas from the faulty cooking appliances in Alexandria Safe Zone community during the zombie apocalypse. Symptoms of COPD in non-smokers are typically milder than those in current or former smokers and do not manifest until a good amount of damage is done. Other risk factors include years of chemical exposure and years of outdoor pollutant exposure. You can develop COPD from inhaling dust or the fumes of fuel burn for cooking or heating purposes. COPD can be caused by chemicals or fumes found in the workplace as well. During the zombie apocalypse, entire communities would sometimes have to be burned to the ground to wipe out an invasion of walkers, using whatever flammable substances were available to start those fires. Inhaling those fumes has impacted Carol's breathing over the years. And to make matters worse, Carol's seasonal allergy flare-ups, if gone unmanaged, can make living with COPD even more miserable. Some modifiable risk factors include exposure to outdoor pollutants, exposure to dust, exposure to tobacco smoke, and exposure to chemicals and fumes. Outdoor pollutants increase the formation of mucus glands and goblet cells and airway epithelium, causing smooth muscle hypertrophy, leading to airway constriction. Exposure to chemicals and fumes increases the recruitment of neutrophils, lymphocytes, and macrophages to the lung, increasing the risk of inflammation and tissue damage. And exposure to dust and tobacco smoke both increase production of thick mucus that is unable to be cleared by the impaired ciliary function, leading to blocked airways. There's also a genetic component to this disease: severe alpha-1 antitrypsin, or AAT, deficiency, the first proven genetic determinant of COPD. Reduced circulating AAT levels are a result of AAT production abnormality. Approximately 1 in 3,000 people in the United States inherit severe AAT deficiency, which substantially increases their risk for COPD, as well as liver diseases such as hepatitis, cirrhosis, and hepatocellular carcinoma. Chronic diseases can also have an effect on the likelihood of developing COPD. Two such chronic diseases are emphysema and chronic bronchitis. With emphysema, alveoli take damage as a result of irritants such as cigarette smoke and/or gases or particles. With chronic bronchitis, inflammation to bronchial tubes causes daily cough and production of thick mucus. Inflammation of lung tissue can be caused by long-term exposure to tobacco smoke, exposure to irritants via occupation, and chronic inflammatory disease such as asthma. Chronic inflammation, matrix degradation, and apoptosis and airway remodeling are all results of long-term exposure to tobacco smoke. With exposure to irritants via occupation, on the job, inspired chemicals leading to bronchial inflammation and edema. Goblet cells and mucus glands increase in size in the airway epithelium, resulting in an increase in size of smooth muscles and hyperproduction of thick, difficult to clear secretions. So again, the risk factors of COPD are indoor air pollution, smoking, chronic inflammatory disease, dust, outdoor air pollution, and chemicals. With indoor air pollution, this can be faulty home or work ventilation, gas leaks, faulty cooking or heating equipment. Smoking, this includes pipe, cigar, and cigarette smoking. Chronic inflammatory diseases such as emphysema, chronic bronchitis, and asthma. The symptoms of those are increased mucus production, smooth muscle hypertrophy, and hyperexpansion of the chest. Complications include air trapping, cyanosis, and anxiety, and treatment would be prevention, proper nutrition, and pharmacologic management. To recap, Carol is 68 years old with a genetic history of lung cancer on her father's side, history of asthma and seasonal allergies. With these seasonal allergies and asthma, chronic irritants can cause neutrophils, macrophages, and lymphocytes to the lungs to take care of the damage. Some modifiable risk factors include exposure to dust at home and at work, exposure to tobacco smoke, exposure to chemicals, and exposure to outdoor pollutants. With COPD, if it goes unmanaged, it can cause hypercapnia or hypoxemia as a result of inadequate gas exchange, a result of either direct or indirect injury to the airways, lungs, or chest wall. And this may present as anxiety, restlessness, irregular breathing patterns, fatigue, and or loss of consciousness. Symptoms of acute respiratory failure are clubbing, hypoxemia, shortness of breath, fatigue, barrel chest, and accessory muscle breathing. Progressive damage is done to the lungs caused by inflammation, oxidative stress, extracellular matrix proteolysis, and cell death. Dyspnea, expiratory wheezes, and edema of the lower extremities is how it will present. And supplementary O2, bronchodilators, and diuretics will relieve the shortness of breath, the wheezing, and the swelling. Because the physiologic changes that take place with COPD are irreversible, prevention is the best treatment. Stay up to date on all vaccinations, flu and pneumonia vaccines, avoid any triggers of a flare-up when possible, avoid secondhand smoke exposure, and begin taking smoke cessation classes if you are a smoker, and remain compliant with all prescribed medications as directed by your physician. Recommended treatment for chronic COPD, prevention, pharmacological, and non-pharmacological interventions are listed here. For prevention, avoid your triggers, stay vaccinated, don't smoke, and remain compliant with your medical regimen as provided by your primary care provider. Pharmacological interventions include bronchodilators, mucolytics, inhaled corticosteroids, phosphodiesterase 4 inhibitors, chronic oral steroids, and macrolides. Your non-pharmacological interventions are chest physical therapy, or CPT, nutritional counseling, respiratory hygiene, monitoring for infection, and effective breathing techniques. Chronic pharmacotherapy, bronchodilators and expectorants to reduce the shortness of breath in COPD patients, mucolytics to reduce cough and for an antioxidant and anti-inflammatory effect. Inhaled corticosteroids, they decrease the number of recurrent flare-ups, increase the quality of life, and reduce the rate of forced expiratory volume in COPD patients. Remember when using these to be careful to monitor for candidiasis, hoarseness, and risk of pneumonia. With phosphodiesterase 4 inhibitors for reduction of inflammation, cough, and sputum production. Macrolides are inflammatory and they reduce the stasis of mucus as well as produce an antibiotic component. And with chronic oral corticosteroids, these are to be used as a last resort. In summary, Carol should be hospitalized for a few days to resolve her COPD exacerbation. During this hospitalization, she should be placed on a BiPAP to correct her blood gases and confusion, be given bronchodilators, mucolytics, and inhaled corticosteroids to reduce shortness of breath, cough, and mucus production, have her daily AM labs done to monitor for development of potential infection. She should be reevaluated closer to her discharge date, and at the time of discharge, she should be given education on prevention, medication, and diet to manage her COPD upon discharge to avoid any recurrent exacerbations.